Hello guys. Today we're going to discuss in cardio nursing all about valvular heart diseases. So as you can see here from the title itself, it involves the valves of the heart. And for you to be familiar with it, you have the following valves here, the structure, the internal structure of the heart. We have the tricuspid valve that is dividing the right atrium and the right ventricle, and the pulmonary valve, which is in between the right ventricle and the pulmonary trunk before the blood reaches the lungs. And we also have the mitral valve or the bicuspid valve, which is in between the left atrium and the left ventricle, and the aortic valve. Before oxygenated blood is going to be pumped out of the aorta, it will pass through this. So those are the four different valves of our heart. Now we go to valvular heart diseases. This refers to the alteration in the structures of the valve that either impedes the blood flow, so it blocks it, or permits regurgitation. So it either impedes or blocks blood flow, or it regurgitates. There is backflow of blood. Remember, the functions of valves, not only in the heart, but also in our veins, is to prevent the backflow of blood. But what happens here in valvular heart disease, it either blocks blood flow or it permits regurgitation. And the aortic and mitral valves are more often affected than the pulmonic and the tricuspid valves. And there are two categories. We have stenosis, which means narrowing, or insufficiency or incompetence, meaning the valve is too weak enough to close. That's why some of the blood will regurgitate or backflow. The etiology of this or risk factors would be either myocardial ischemia or atherosclerosis. So there are coronary artery disease. Another would be inflammation of the endocardium. So the endocardium, which is the inner lining of the heart, is somehow inflamed due to infection. Or there are also congenital abnormalities of the heart brought about by congenital heart disease. Now we go to the first one, mitral valve disease. Number one is mitral stenosis, which is the narrowing of our mitral valve. Now this now will interfere with the left ventricular filling and produces pulmonary hypertension and right ventricular failure. And this one, it is caused by rheumatic endocarditis. So it's caused by an infection. So what happens here is that with mitral stenosis, remember the mitral valve or the bicuspid valve is the valve that is in between our left atrium and the left ventricle. If there is a narrowing of this, the blood that is supposed to go down the ventricle will go back to the pulmonary veins, causing now pulmonary hypertension. And of course, if that happens, blood is going to further go back, causing now right ventricular failure. So effects, there is reduced blood flow, of course, to our left ventricle, because how is blood going to pass through the narrowed mitral valve if that valve is or has a narrowing? There is also left atrial hypertrophy because of the too much pressure that is building up in the left atrium. The tendency of the muscles there, the cardiac muscles, is for it to hypertrophy. Take note, since the left atrium um, is taking in too much workload from that increased amount of blood volume in it, the cardiac muscles there are going to hypertrophy. That's what usually happens if there is too much workload brought about by a certain disease, or just like the skeletal muscles, for example. If you put too much work on them, normally our skeletal muscles are going to hypertrophy, which is a normal occurrence. But this is a big no-no to our cardiac muscles, because if our cardiac muscles hypertrophy, that can lead later on to cardiac or cardiomyopathies. So we are avoiding that from happening. Another can, so there will be left atrial hypertrophy. It will also lead to pulmonary hypertension, because the tendency, like what I said earlier, is for the blood to backflow back to the pulmonary veins. And there will be right ventricular hypertrophy and failure. So the right side of the heart will also hypertrophy, brought about by the backflow of blood. And eventually this can lead to heart failure. So the pathophysiology of this, there's a narrowing in the mitral valve or mitral valve. Left atrium has great difficulty moving blood into the ventricle because of the increased resistance of the narrowed orifice. So since there's a narrowing there, tendency is it will give too much work on the left atrium. So this now will dilate in hypertrophy due to the increased blood volume. And since there is no valve to protect the pulmonary veins from the backward flow of blood from the atrium, the pulmonary circulation is going to be congested, leading now to an increase in the blood pressure in the pulmonary veins. So as a result, the right ventricle must contract against an abnormally high pulmonary arterial pressure and is subjected to excessive strain, until eventually the right ventricle is going to fail. So that is what happens with regards to mitral stenosis. Signs and symptoms. There's dyspnea on exertion. So when the patient is doing an activity and has a mitral stenosis, this can cause dyspnea as a result of pulmonary venous hypertension. Because how is blood going to go through the stenotic mitral valve if it's narrowed? So the patient will have a hard time taking in oxygen because of that pulmonary venous hypertension. There's also progressive fatigue due to low cardiac output, because there's only a little amount of blood that can pass through that stenotic valve. There is hemoptysis. When we talk about hemoptysis, this is blood in the sputum. So if the patient's sputum is streaked with blood, this is it, hemoptysis. There's also cough. And they can have repeated respiratory infections due to pulmonary congestions. So this can occur if there is pulmonary congestion brought about by the backflow of blood to the lungs. The assessment and diagnostic findings is that the pulse is weak and it is often irregular because of atrial fibrillation. So what happens here is that the atrium is working too much that it fibrillates. They can detect this through ECG. And you can hear a low-pitched rumbling diagnostic murmur, which is heard at the apex. So how are we going to manage this? Prophylactic antibiotics are used to prevent the recurrence of infections, and also coagulants such as warfarin or Coumadin to decrease the risk of thrombus formation, because thrombus formation is imminent in this disease, most especially at the atrium, since there's an increased pressure of blood there. If there is an increased pressure of blood building up inside a chamber, the tendency is for it to produce thrombi or thrombus. And while giving warfarin, make sure that we are going to check the prothrombin time and also the partial thromboplastin time before giving the drug. If just in case heparin is the one that is given. The normal value for PT or prothrombin time is at 10 to 12 seconds, while for partial thromboplastin time, it's at 30 to 45 seconds. And the surgical management for this disease is the surgeon is going to perform valvuloplasty, wherein they are going to repair that valve that is stenotic or narrowed. So it's done through surgery. In order for you to remember which drug is for which laboratory test, you need to remember this. Or remember, there are 7 letters in heparin, plus 3 to make it 10, plus 3 letters from PTT or partial thromboplastin time. So if you are giving heparin to a patient, make sure to monitor the patient's PTT. While if you are giving Coumadin, Coumadin has 8 letters, we are going to monitor the patient's PT. So that's equal to 10. Coumadin plus PT, 10. So the prothrombin time is the one checked whenever we give the patient Coumadin. So always remember this. So this is an illustration of an ECG reading that shows atrial fibrillation, meaning that the atrium is receiving too much pressure from that blood volume that is supposed to go down the mitral valve. So this is an example, a real example of a stenotic mitral valve. Another is number 2, mitral insufficiency, wherein there is leaking or regurgitation of blood back into the left atrium, leading to pulmonary hypertension and right ventricular failure. As you can see here, the blood is going back. There's backflow of blood or regurgitation through the mitral valve. So there is insufficiency, meaning it doesn't close properly, or it is weak enough to close properly. Effects, there's left atrial dilation again. There's an increased pressure in the left atrium, so it will dilate and hypertrophy, similar to that of mitral stenosis. Again, this pressure will go back to the pulmonary veins, causing now pulmonary hypertension. And eventually it'll lead again to right ventricular hypertrophy. Signs and symptoms, usually this is asymptomatic, but acute mitral regurgitation is brought about by MI. So if there's myocardial infarction, it can cause mitral regurgitation or mitral insufficiency, or it usually manifests as part of severe congestive heart failure. So if it's brought about by MI, or if the patient has had MI, it can lead to mitral regurgitation. Or if the patient has severe heart failure, this can also happen. Dyspnea, fatigue, and weakness are common in this disease. Palpitations are also felt by the patient, and shortness of breath as well. Cough, of course, is usually felt due to pulmonary congestion. So these are the usual signs and symptoms, similar to that of mitral stenosis. Dyspnea again is present because how is oxygen going to pass through or go through the mitral valve if it's either stenotic or if there is insufficiency? Assessment and diagnostic findings is that a systolic murmur is heard as a high-pitched blowing sound at the apex. And the pulse may be regular and of good volume, or it may be irregular as a result of extrasystolic beats or atrial fibrillation. So pulse can be normal or it may be irregular. You can notice certain extrasystolic beats when you palpate the pulse or you auscultate the apical pulse of the patient. During an echocardiography, you can see that, or the doctor will be able to see that there is mitral regurgitation. It will be evident through ultrasonography. Medical management. Medical management of this is same with congestive heart failure. If heart failure is present, they will give medications for it, such as digoxin or lanoxin, which is the drug of choice for patients who have heart failure. And if the mitral valve really doesn't work due to insufficiency, they are going to replace it. There will be mitral valve replacement or valvuloplasty. Again, surgery is going to be done on the patient. The third one is the mitral valve prolapse. So what happens here is that one or both of the leaflets of the mitral valve will bulge into the left atrium during ventricular contractions. So it is bulging into the left atrium, like what you can see here. This is an example of it. So whenever the ventricles contract, the mitral valve is prolapsing into the left atrium. It should not prolapse into it. The valves or the leaflets should be closed during ventricular contraction, and it should not prolapse into the left atrium. So as you can see here, for normal closed mitral valve, it should appear like this. But in mitral valve prolapse, one or both of the leaflets are going towards the left atrium. So it doesn't close properly again. So the management of this, it's the same as that of mitral valve insufficiency. Again, they need to repair the valve that is malfunctioning. Next, aortic valve disease. So the first is aortic stenosis. There's a narrowing in the orifice of the aortic valve, which causes a decrease in cardiac output and an increased pressure in the left ventricle. So we are talking about the aortic valve now. So what happens here, since there's a narrowing in the aortic valve, the blood flow will not go through it, and instead it will go back into the left ventricle. Once that happens, the left ventricle will have an increased workload due to the amount of the blood volume that it handles. It will dilate and later on hypertrophy. So the cardiac muscles there are going to or will have a hypertrophy. And of course, the cardiac output is going to be decreased this time. So pathophysiology of this. So if there's a progressive narrowing of the valve orifice, the aortic valve, usually over a period of several years to several decades, the left ventricle overcomes the obstruction to circulation by contracting more slowly. But even though it contracts slowly, it uses greater energy than normal. So it forcibly squeezes the blood through that very small orifice. It tries, the left ventricle will try to force it out of that very small orifice. And if that obstruction to the left ventricular outflow in turn increases pressure on the left ventricle, which will later on lead to this hypertrophy. Like what I've mentioned earlier, it will thicken the muscle wall of the left ventricle. And once that happens, the heart muscle hypertrophies, and this now later on can lead to heart failure. When these compensatory mechanisms of heart begin to fail, clinical signs and symptoms of heart failure will develop from it. Because if anything hypertrophies inside the heart, especially the myocardium, that can lead later on to heart failure. Those who have aortic stenosis, they are usually asymptomatic, so they don't exhibit any signs and symptoms. But patients usually first, again, they have exertional dyspnea. So when they are doing strenuous activities, for example, just caused by left ventricular failure. Other signs that the patient is going to feel would be dizziness and syncope. Syncope is fainting spells. So they sometimes faint because of a reduced blood flow through the brain of the patient. And angina pectoris is also a frequent symptom that results from the increased oxygen demands of the hypertrophied left ventricle. So imagine the left ventricle has hypertrophied. It has thickened. So what happens, it will increase or it will demand more oxygen. But if lesser oxygen isn't delivered to that hypertrophied left ventricle, the patient is going to experience angina. Why? Because of that narrowed orifice in the aortic or in the aortic valve. So how is the blood going to pass through it and deliver oxygen through the coronary arteries if that is blocked or that is narrowed? So the patient is going to feel chest pain. Or the other term would be angina pectoris. Once that happens, blood pressure can also be low, but is usually normal. And there may be a low blood pressure or pulse pressure rather, which is 30 millimeter mercury or less because of the diminished blood flow. So you will notice that with the pulse of the patient. Assessment and diagnostic findings is that you are going to hear a loud, rough systolic murmur that is heard over the aortic area of the chest. The sound to listen for is a systolic crescendo-decrescendo murmur, which may radiate into the carotid arteries and to the apex of the left ventricle. So take note, the type of murmur that you can hear in aortic stenosis would be a crescendo or systolic crescendo-decrescendo murmur. The murmur is low-pitched, rough, rasping, and vibrating. If you are going to put your hand over the base of the heart, you can feel a vibration. There's a vibration there. This vibration is caused by the turbulent blood flow across the narrowed valve orifice. So, tendency is, since there is a narrowing of the blood of the aorta or aortic valve, the blood that is passing through it becomes turbulent. So imagine a water hose that you are partially covering with your thumb, for example. The water becomes turbulent. If that happens, same is true with aortic stenosis. And evidence of left ventricular hypertrophy can be seen on the 12-lead ECG or through an echocardiography. So through sonogram, the doctor will be able to see that hypertrophy. Echocardiography is used to diagnose and monitor the progression of aortic stenosis. So every now and then, the patient will undergo echocardiography. And after the stenosis progresses to the point that surgical intervention is considered, left-sided cardiac catheterization is necessary to measure the severity of the valvular abnormality and evaluate the coronary arteries as well. So, patient may undergo cardiac catheterization first before surgery will be done on the patient. This will evaluate how large, or how small rather, how small the orifice of the aortic valve has, as well as the coronary arteries as well. Medical management. Antibiotic prophylaxis is given to patients to prevent endocarditis, and it is essential for anyone who has aortic stenosis. And the definitive treatment for aortic stenosis is the replacement of the aortic valve. So surgical replacement is going to be done for this patient. Patients who are symptomatic and are not surgical candidates, they may benefit from 1 or 2 balloon percutaneous valvuloplasty. So this procedure, 1 or 2 balloon percutaneous valvuloplasty, what they do here is they do this through cardiac catheterization. So they perform this one. They are going to insert a catheter into the patient's blood vessels. It's a balloon tip catheter, by the way, wherein they are going to insert this and inflate the balloon at the site of stenosis. Let's say, for example, the aortic valve. If it is successful, then surgery or open heart surgery may not be needed. So there, as you can see, the aortic valve, the normal aortic valve should have 3 leaflets, but in aortic stenosis, it becomes bicuspid, since the other 2 leaflets have combined, causing stenosis to occur. Now, for senile aortic stenosis, what happens here is due to the deposits of plaques, for example, on these valves, they will, or tendency is that they are going to harden. If they harden, it will have, or this valve will have a hard time opening, allowing blood to pass through them. So for senile aortic stenosis or bicuspid aortic stenosis, this can occur. So as you can see here, this valve has plaque formations on it, causing aortic stenosis to occur. Next, we have aortic insufficiency. There's an incomplete closure of the aortic valve, now causing backflow of blood into the left ventricle from aorta, or from the aorta during diastole. So since the valve is incompletely closed, tendency for it is to go back into the left ventricle. So again, anything that goes back into the left ventricle will cause an increase of blood volume, leading to dilation and hypertrophy of the left ventricle. Again, there will be a decrease in the cardiac output. Pathophysiology of this is blood from the aorta returns to the left ventricle during diastole, in addition to the blood that is normally delivered by the left atrium. So the left ventricle now dilates, which is trying to accommodate the increased volume of blood coming from the aorta. Again, it will hypertrophy, similar to that of aortic stenosis. It will try to increase muscle strength in order to expel more of that blood, which is above normal force, raising the systolic blood pressure. And the arteries attempt to compensate for the higher pressure by reflex vasodilation, while the peripheral arterioles relax, reducing peripheral resistance and diastolic blood pressure. So what happens here, since there is high blood pressure or coming from, what do you call this, the left ventricle of the heart, what happens here is that the arteries try to compensate by vasodilating. While they vasodilate, the peripheries or the arterioles of the peripheries, the limbs or the arterioles, they relax. If they relax, this will reduce peripheral resistance and diastolic blood pressure. Signs and symptoms, this one again is asymptomatic in most patients, but the patients may be aware of a forceful heartbeat, most especially of the head or in their neck. And there may be marked arterial pulsations that are visible or palpable at the carotid or temporal arteries. So you can see their carotid arteries, it is visible. The pulsations are visible here on their neck. Exertional dyspnea is again common in this disease if they are doing an activity and they will be easily tired. Fatigue is going to follow after an activity is done. Progressive signs and symptoms of left ventricular failure include breathing difficulty, such as orthopnea. What do we mean again by orthopnea? They are experiencing, they can be relieved rather from dyspnea if the patient is placed in an upright position. Or there is paroxysmal nocturnal dyspnea. They usually experience dyspnea during nighttime. So that is what paroxysmal nocturnal dyspnea is about. Now with the assessment and diagnostic findings, a diastolic murmur is heard as a high-pitched blowing sound at the third or fourth intercostal space at the left sternal border. So it's in between the third or fourth intercostal space in the left side of our chest, the left sternal border. So take note, that murmur is heard at the third or fourth intercostal space. It's a blowing sound that you can hear. The pulse pressure is considerably widened in this condition. And one characteristic sign of the disease, take note, class, that this one has the water hammer pulse. So it has the water hammer pulse, in which the pulse strikes the palpating finger with a quick, sharp strokes, and then it suddenly collapses. So if you are going to palpate the pulse of the patient, you will feel for quick, sharp strokes. Then it suddenly will collapse. That is the water hammer pulse. This is the characteristic sign of this disease. Diagnosis is confirmed by echocardiogram, radionuclide imaging, ECG, magnetic resonance imaging, and cardiac catheterization. Our nursing responsibility when the patient is going to have an MRI or magnetic resonance imaging is that we are going to remove any metallic object from the patient's body. That is our responsibility. Why? Because with this diagnostic procedure, the patient or the MRI is going to use a very strong magnet in order to visualize the internal organs of the patient. Since magnet is used Our responsibility is to remove anything or any object that is made of metal from the patient's body. Is that clear? So if the patient has a metallic object such as a bracelet, or let's say, for example, jewelry, earrings, and so on, we need to have these things removed. But what if, for example, the patient has rods and pins on their bones, for example, or if they have a pacemaker for their heart, or if they have braces on their teeth, will they be allowed to have an MRI scan? No, they wouldn't. They would. The doctor is going to do a different type of diagnostic procedure instead. If the patient has metallic objects in their body, but if it is on the body, we need to remove it. If it's in the body, other diagnostic procedures are going to be done. And make sure that you or we are going to remove the stretcher or the wheelchair where we brought the patient with from the MRI room, or else it's going to be, or the magnet is going to attract these objects and it's going to be dangerous for the patient. To take note, once the patient is already in the MRI room, remove either the stretcher or the wheelchair because these are also made of metal. Medical management. Before the patient undergoes invasive or dental procedures, antibiotic prophylaxis is needed again to prevent the occurrence of endocarditis. And if there are signs and symptoms of heart failure and dysrhythmias, they are treated with, again, digoxin if heart failure is present. Again, aortic valvuloplasty or valve replacement is going to be done. This is the treatment of choice. It's preferably performed before left ventricular failure will happen. So surgery is recommended for any patient who has left ventricular hypertrophy, regardless of the presence or absence of a symptom. So in order to repair that valve that is malfunctioning, this needs to be surgically repaired or replaced. Now we go to tricuspid valve disease. First is tricuspid stenosis. There is narrowing of the tricuspid valve that interferes with the right ventricular filling and increases right atrial pressure. So what happens here is that this tricuspid valve is narrowed. So what happens is instead of the blood going down the right ventricle, it goes back here, increasing the pressure in the right atrium. If there's also tricuspid stenosis, there's also tricuspid insufficiency. So there will be leaking of blood back into the right atrium because of this not closing properly. The tricuspid valve is not closing properly here. So effects of both of these diseases would be decreased cardiac output, and there will be a lesser amount of blood going into the lungs. Remember, this is the right side of the heart. There's increased atrial pressure and systemic congestion is going to occur. What are signs and symptoms of systemic congestion of blood or fluid? Since there is backflow of blood in the right side of the heart, it will further backflow into the vena cava, causing systemic congestion that later on leads to hepatomegaly or enlargement of the liver, splenomegaly or enlargement of the spleen, and you can see their jugular veins, they are distended. It is very obvious on the neck of the patient. Or this can later on lead to edema of the extremities. Pulmonic valve disease. It is the narrowing of the orifice of the pulmonic valve. And once this is narrowed, again, there will be decreased cardiac output and increased pressure now on the patient's right ventricle since there is a narrowed pulmonic valve. Remember, The pulmonic valve is the one that is found in between the the right ventricle and the pulmonic trunk. The pulmonary trunk is the one that leads blood into the pulmonary arteries going to the lungs for the collection of oxygen. Another would be pulmonary insufficiency. Similar to the other insufficiencies, there's incomplete closure of the pulmonic valve, causing backflow of blood into the right ventricle again. So instead of it going into the lungs, it goes back into the right ventricle. So effects of these two would be, again, this decreased cardiac output, and the right ventricle is going to have an increased pressure. Once that happens, the right ventricle is going to dilate and hypertrophy. Once it hypertrophies, that can further lead into heart failure, right-sided heart failure. If right-sided heart failure occurs, the previous signs and symptoms that I've mentioned, hepatomegaly, splenomegaly, ascites. Ascites is accumulation of fluid into the abdominal cavity brought about by increased blood pressure in the liver. So since the liver cannot take that blood pressure, the fluids leak from it, leading to ascites. The clinical manifestation of ascites is increase in the abdominal circumference. So the patient may appear pot-bellied because of the fluid accumulation in the abdominal cavity. Another will be distended jugular veins and edema of the hands and feet. Those are signs and symptoms of systemic congestion. So as you can see here, there is pulmonary regurgitation of blood. So it goes back into the right ventricle due to insufficiency. But here, since there's a stenosis, a little amount of blood is going to go through it. So there will be narrowing. That's the narrowing of valve between right ventricle and the pulmonary artery. Regurgitation of blood from the right ventricle back into the right atrium. Valve leaf left bulges into the left atrium during systole. And once that happens, since there is a little amount of oxygen circulating in the blood, why? Because there's only a little amount of oxygen going through the pulmonary arteries, going to the lungs for the collection of oxygen. So if that happens, the patient may have a bluish discoloration of the face. There is positive Corgan's pulse. I'll show that to you later on. Positive mitral click during auscultation. So if you auscultate the patient, you can hear this. And there is decreased left ventricular filling and increased pressure on the left atrium. So only a little amount of blood will be contained in the left atrium because the lungs are not receiving that much blood from the right side of the heart. Positive mitral fasces, which is the patient has rosy cheeks, but the rest of the face is cyanotic. It's the reddish or bluish discoloration of the face. So here I'm showing to you the demonstration of the Corgan's pulse. So it's very, very evident here. It's brought about by the backflow of blood into the veins. So there. This one is mitral fasces, wherein the patient has rosy cheeks, but the rest of the face is either pale or bluish. Clinical manifestations due to decreased cardiac output. Again, the patient will feel weak and there's fatigue. They easily tire out with an activity. There's shortness of breath. They will appear pale. There's low blood pressure because of this very low cardiac output. Weak, irregular pulse is felt by the nurse, And a water hammer pulse is also present here in this condition. For pulmonary congestion, orthopnea is also present together with paroxysmal nocturnal dyspnea. Increased respiratory rate is evident as well, and there's shallow respirations. They try to increase respiration. This is a compensation for the little amount of blood that is circulating in the patient's body. Now, if pulmonary congestion occurs, hemoptysis is also present, wherein there's blood in the sputum, or there's pink frothy sputum. You can see that the characteristic of the sputum of the patient is that of a strawberry milkshake. And if you auscultate the lung fields of the patient, you will be able to hear crackles. So this is the pink frothy sputum. It's like a strawberry milkshake, but the real one looks like this here or here. So that's a result of pulmonary congestion. Systemic congestion, like what I've said earlier, the peripheral edema or cyanosis can also be present. Jugular vein distension, hepatojugular reflux. So that is also present. I've also mentioned ascites earlier and congestive hepatomegaly. Okay, class, take note. For pulmonary congestion, these signs and symptoms here are also evident for patients who are experiencing left-sided heart failure. These are the signs and symptoms of left-sided heart failure. So if the heart or the left side of the heart fails to pump blood, tendency is for the blood to backflow into the lungs, resulting now to pulmonary congestion. And the signs and symptoms, they are primarily pulmonary in origin. So signs and symptoms are coming from the lungs. The patient has dyspnea, the patient has frothy sputum, crackles, hemoptysis, and so on. These are all pulmonary manifestations that is indicative of left-sided heart failure, because the backflow of blood, it goes back to the lungs, causing pulmonary congestion. But for right-sided heart failure, systemic congestion is going to occur, since the backflow of blood in the right side of the heart will go back to the rest of the system through the vena cava. What are they? We have our organs, such as the liver and the spleen, which is part of the abdominal cavity. It will primarily backflow there. And the jugular veins, they can be very evident. And of course, our extremities, they are going to experience edema. Cardiac manifestations would be murmurs, so they can you can hear murmurs if you auscultate it, which are sounds produced by abnormal or turbulent blood flow. An S3 heart sound is going to be heard, which is also known as the ventricular gallop. It occurs after S2 when the mitral valve opens. So it's abnormal. Instead of hearing just lub-dub, 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 you are going to hear lub-dub-dub, 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 lub-dub-dub. That is known as the ventricular gallop. You can check also for ECG changes. You're trained enough to read ECG, and the patient is of course going to experience angina pectoris because of the little amount of oxygen circulating in the left side of the heart. So if the cardiac muscles are receiving a little amount of blood, that's also a little amount of oxygen, the patient is going to experience chest pain or angina. So there you can see jugular vein distension on the patient. This is an example of what ascites looks like. There's distension of the abdomen because it is fluid filled. Okay, so these are the chambers of the heart. Diagnostic tests, either cardiac catheterization is going to be done, X-ray, of course, echocardiography is done to detect how small the opening is for the valves, or the stenosis is also detected there. Electrocardiography is going to be done in order to check for ECG patterns. So this is how cardiac catheterization is done. This usually, this one is the left side of the heart. So here, through cardiac catheterization, like what I've mentioned you in my earlier lecture, they use a dye in order to visualize these blood vessels here. Like this, for example, they are trying to visualize the coronary arteries. This is an example of an echocardiography, wherein with the use of ultrasonic waves, the sonography will visualize the chambers of the heart here, how large or how small the valves are, how large the muscles of the heart has, and so on. So there, that's how echocardiography is done. Take note of my previous lecture with regards to diagnostic procedures. Make sure to maintain privacy once this is done, most especially if the patient is a female. Management. Maintain a normal cardiac output, improve cardiac function and activity tolerance. That is our goals for our patient who has these kinds of valvular heart diseases. We need to monitor the patient's hemodynamic status. Example, every 1 to 4 hours. We need to auscultate the breath and heart sounds. Daily weight checks should be done, and check for murmurs and edema as well. Oxygen therapy if the patient is experiencing dyspnea to improve oxygenation and relieve the patient from respiratory distress. And plan rest periods because the patient is constantly tired from these types of diseases, valvular heart disease. So make sure to provide them with bed rest. Because one of the nursing diagnoses that you can formulate from these diseases would be activity intolerance, because they will feel tired just with a small amount of activity that they've done for the day. You also need to limit visitors, activity, and noise at the patient's house. Administer the following medications as ordered: digitalis or digoxin and other inotropic agents such as dopamine and dobutamine. With regards to the administration of digoxin, it is very, very important for us nurses to know if the patient is already experiencing toxicity from this drug. So if the patient has visual disturbances, that is an adverse effect of this drug, or it's an indication that the patient is already suffering from toxicity from digitalis. If they see yellow halo around lights, that is already a sign of toxicity from digoxin. So we need to check that every now and then. If the patient tells you that there's something weird about how I see lights, then perhaps the patient is suffering from toxicity. ACE inhibitors such as captopril and enalapril are given to control hypertension, most especially pulmonary hypertension. Diuretics if the patient is experiencing any edema of the extremities. Like what we've mentioned, every now and then from this lecture, antibiotics are going to be given, most especially prophylactic antibiotics. There's also a tendency to develop blood clots because of the increased pressure in specific chambers of the heart. In order to prevent that from happening, we give anticoagulants. But we need to monitor always these two laboratory values, the PT and PTT. I repeat, heparin, PTT is monitored, while for Coumadin, it is PT that is monitored. Do not interchange the two. Always remember the rule of tens when it comes to the monitoring of heparin and PTT, Coumadin and PT. We also need to monitor the patient's compliance or response to medications. We need to evaluate if they are improving with these medications. We need also to monitor the patient's fluid and electrolyte imbalance, or balance rather. Their intake and output is very, very essential, most especially if we're giving diuretics. That's one of our nursing responsibilities when giving diuretics, such as furosemide. Also, if you're giving specific types of diuretics, such as furosemide, you need to also check their lab results for electrolytes, most specifically that of potassium, since furosemide is a potassium wasting diuretic. Monitor the patient's weight as well every day, lung sounds, and for the presence of edema. Dietary modifications, they are needed as well to control the intake of salt. For example, because salt can attract water, water can be increasing the blood volume. Water can contribute more to the blood volume of the patient for the increasing the blood pressure. And activity restrictions if it is indicated by the doctor. Educate the patient in possible care for valvular surgeries. We need also to alleviate the patient's anxiety when it comes to the surgery. We need to inform them on what the surgery is going to be about. Because of course the patient, any patient who will undergo any type of surgery is going to be anxious. So we need to allay their anxieties by talking to them. And monitor for complications of heart failure. You all well know the difference between the two types of heart failure. For right-sided heart failure, signs and symptoms are systemic manifestations. While for left-sided heart failure, the manifestations are only found in the lungs. Is that clear? So that's the difference. For surgical management, candidates for surgery are those who are symptomatic or those with progressive impairment of cardiac functioning. So if their condition is further worsening, they need surgical management. And there's also gradual enlargement of the heart, most especially if the patient is experiencing left-sided hypertrophy or right-sided hypertrophy. One of the management that they will go, that the surgeon is going to do is valvuloplasty, repair or reconstruction of the cardiac valve, and commissurotomy, the commissures. These are the things that you can find on the patient's valve, on our valve rather. There's open commissurotomy, so they are going to further increase the lumen or the opening of the valve. Closed surgical commissurotomy and balloon valvuloplasty. Commissurotomy is done to patients who have stenotic valves. They will try to increase the diameter or the opening of the valve in order for blood to pass through it. Annuloplasty, this is the repair of the valve annulus. And chordoplasty, it's the repair of the chordae tendineae if the chordae tendineae is the one that is malfunctioning. So A is an example of commissurotomy. This is open commissurotomy. B is um, annuloplasty, while C is chordoplasty here. So these are examples. In the annuloplasty, this is how they are going to repair it. They are going to secure the valves by placing a ring around it. So that is involving the annulus of the valves. So this is how they do it. So there's a ring that is placed around the valve to secure it into place. Or they do this as well. If there is any prolapse that is happening, they remove that prolapsed portion and repair it. Again, this is an example of annuloplasty. And for the repair of chordae tendineae, they use an artificial chordae for this. Another would be valve replacement. So if it's impossible for the valves to be repaired, they're going to use prosthetic valves instead, such as the use of mechanical valves. The ball and cage or disc valve is used, or tissue valves, xenografts. These are tissue valves from pigs or cows, so from animals. Homografts or allografts, they're obtained from cadaver tissue donations. So for example, if a patient is already brain dead, clinically dead, they can gather the organs of the patient for tissue donations, such as this. Autografts, they are obtained by excising the patient's own pulmonic valve in a portion of the pulmonary artery for use as the aortic valve. So it's coming from the patient himself or herself. That is the autograft. So here, this is an example of a prosthetic valve. This is the ball and cage type of valve. So with this mechanism, once blood is going to pass through it, the ball will go down. And once the ventricle contracts, the ball closes that opening there in order to prevent the backflow of blood. So this is another example of a prosthetic valve. Nursing management after valvuloplasty and replacement is done. Vital signs are assessed like any other post-op management from every 5 to 15 minutes until it is as needed, till the patient recovers from the anesthesia or sedation. And later on, once they've recovered from anesthesia, they are assessed every 2 to 4 hours as needed. IV medications are given to increase or decrease their blood pressure, also to treat dysrhythmias or any altered heart rates. So they are administered and their effects are going to be monitored as well. The IV medications are gradually decreased until they are no longer required by the patient, or they can take it via another route, such as oral or topical. Patient assessments are also conducted every 1 to 4 hours, and there is particular attention to neurologic, respiratory, and cardiovascular systems during patient assessment. And there will be long-term use of anticoagulants brought about by these types of surgery. So explain the need for frequent follow-up appointments for blood laboratory studies and teach them the side effects of these drugs, the name of the medication, whether it's heparin or promethazine, the dosage, their action, when the patient is going to take them, their schedule, the potential side effects, and any drug or drug-food interactions. So we need to educate them about the drugs that the doctor is going to prescribe them. And patients with a mechanical valve prosthesis requires education to prevent bacterial flow or bacterial endocarditis with antibiotic prophylaxis, which is prescribed before all dental and surgical intervention. So they will be given antibiotic prophylaxis. It's in order to prevent the occurrence of endocarditis. So that's it with regards to valvular heart disease. If you have any questions about my lecture for this, please do not hesitate to message me. I'm available most time of the day. You can ask me questions about it. We'll continue our topic with regards to cardio nursing with infectious diseases of the heart. Okay, thank you very much for today's session. Have a great day.